Hello, good evening, everyone. I hope all of you can hear me. Welcome to this first webinar on understanding the MRCOG Part 3 exam. I welcome you on behalf of the Med Exam Expert team today. So we will be holding a series of webinars. The first one today, in which we try to talk about the initial steps and the strategy in the preparation for Part 3 exam. It will be followed by sessions by Dr. Sidra Ali and Dr. Mohammed Hassan, whom all of you are familiar with because they are mentors for the Part 2 course, and all of you are familiar with them. Dr. Sidra will be talking about how to deal with an angry patient. Dr. Mohammed Hassan will be talking about how to prepare structured discussion stations. Today, I'm going to talk about few general things about how to start preparation. Myself, I am Dr. Pooja Sharma Dimiri, and I finished my MRCOG Part 3 in 2018. I cleared Part 1, Part 2, Part 3. Part 1 I cleared long time back, but Part 2 and Part 3 simultaneously in the first attempt in 2017 and 18. And since 2018, I have been the mentor for Med Exam Expert Part 3 course. We started our first batch in 2018, August, when me and Dr. Tanushree Rao were the mentors for the course. Later on, Dr. Sidra Ali and Dr. Mohammed Hassan joined us, and our course has grown from strength to strength. So traditionally, we have been holding two kinds of courses for Part 3 exam. One is the intensive course, which is going to start shortly. And this is the course I'm going to talk about today. This is intensive course. It's a 2-month course in which we take around 2 modules in each session, and the number of stations are more. The other course, unfortunately, which we didn't have for this exam because of all the situation going on and the uncertainty behind the exam, is a long course, which is a 4-month extensive comprehensive course in which we take 1 module per session, and it's a more detailed course for each module, and it's a slow, sustained preparation. As we all know, the past year has been quite uncertain, and especially as far as these exams are concerned. All of you have been in this dilemma and this confusion for the last 1 year about the exam. Thankfully, Part 1 and Part 2 exams have been conducted and the results are out. The Part 3 exam has not happened for over a year now, but hopefully this Part 3 is happening in 2021 in May. So this course will be designed targeting Part 3 May exam. But of course, those candidates who are planning to attempt the exam after May 2021 will also benefit from this course because it will give you an idea how to start preparation. And most importantly, the Part 3 is about the strategy and the type of preparation you do rather than the amount of preparation you do. It's very important. You all know that the MRCOG exam is a long journey. And because of the COVID and the happenings in the past year, this journey has been prolonged, unfortunately, for all of us. I'm not sure what kind of participants we have today, many of you will be absolutely new to the part 3, those who have just finished the part 2. And it's very common and very natural to feel lost in the beginning of the preparation, because part 3 is completely poles apart from part 1 or part 2 exam. Of course, I completely agree that part 2 is a very difficult kind of exam, and I think it's the most difficult part of the MRCOG exam. And you all, after passing part 2, have actually cleared the most difficult part. Part 3, on the other hand, is not that difficult if we follow a particular strategy and plan in preparation. It cannot be cleared without a concrete plan and strategy. Few years back, I was in the same boat as you all, and in the beginning, I was really flabbergasted, really confused about how to start preparation. And it's very important to take a step back, ponder, and think about how are you going to do this. So let's try to figure out how to prepare. Now, part of this lecture today will be philosophical, but believe me, these things are also very important to understand, especially at the beginning of the preparation. One is patience. At many times during the course of preparation, you will feel frustrated. You will feel that you are not able to manage. You feel you are not understanding what is happening. You see the other candidates, other participants in the course or otherwise when you're preparing with various kind of people, and you feel they are much ahead and that you are not doing well. You have to have that patience. You have to believe in yourself and carry on. You should believe me when I say that I felt like that multiple times when I was preparing for part 3. And it was till the end moment, till I actually gave the exam, I was feeling the same way. But I passed the exam. So all of us can do it. You have to have that patience and faith in yourself. Second is persistence. You have to keep at it. It has to be a daily preparation. I know all days are not the same. We all, when we prepare for part 3, we are working, we have families, we have a lot of things to do. You may not be able to focus every day at the same level, but still keep persisting. Try to finish one portion, try to do few stations every day, and hard work. These are very, very important for this exam. And I'm sure all of you are very hardworking people and would be able to do that. For this exam, you need basic communication skills. First thing is listening. I know it is a talking exam. It is a speaking exam. In the exam, you sit in front of the examiner. You have the role player in front of you, and you're going to talk. And what you talk is what will determine your score in the exam and your success in the exam. But more important than talking, or I can say that what determines what you talk is what you have listened. It's an interactive exam. You have to listen to the role player who's sitting in front of you, because you have a question, but you don't know the details. The details you have to seek from the person who's sitting in front of you, who's the role player in case of the simulated patient task, and the examiner in case of structured discussion stations. So active listening is the first most important step in this part of the exam. So keep your ears and eyes and your mind open when you're sitting in the exam. Listen. We'll be talking this multiple times whenever we are talking about the exam preparation. When we talk about the station, you have to listen to the role player, listen to the examiner when they're asking questions. Second is writing. Now you'll ask me, it's not a writing exam. It's just an oral viva type exam. And why have I written this? Writing is not important per se for the exam day, but writing is very important when today you start your preparation. Whatever you listen to or you study from books or from courses or practicing with your fellow participants or your friends, you should make a note. You should make your templates yourself. Of course, when we teach you, when we talk about the modules, about stations, we give you points of preparation, we give you templates. There's a lot of information available on the internet, on various groups, but you need your own writing. You should be able to make your own template for various kind of stations. These are the things which will actually help you in the last few days of the exam. I'll be talking about the phases of preparation a little later on, but this is going to help you the last few days, because what you do today, 2 months prior to the exam date, you're not going to remember everything. In the end, you need a revision, quick revision. For example, you're doing a station on urogynecology. For urogynecology, you'll have a particular set template of questions and what you are going to examine in the patient and what management options, small points. So if you've written on one paper, if this is for urogynecology, you read it in the end before the exam, you will remember it easily. Because in an exam, you need to have you have to be very quick with your reflexes. You need your presence of mind. So basic things you should not be thinking about them. They should come to you naturally. And for that I say, writing, you should have your own notebook in which you have written your own points for various things. It's always good. Of course, you can refer to your friends, you can refer to a lot of information which is available in various preparation groups. But if you write it in your own handwriting, understand and write and make your own notes, they are going to be of the best help. That is what helps me. Reading. Now, what are we supposed to read for this exam? So we'll be discussing in detail a little later, but you'll be reading your books, you read the templates available, you read what information is given in your courses, and assimilate that information to be used in the exam time. Last but not the least is speaking part. So this is what we are going to practice. This is what you have to practice. Now, where do we practice this? And how do we practice this? The speaking has to be practiced on your own. It is described that you can stand in front of the mirror and practice when you're alone. You should have a person or a group of persons or your study partners, your study buddies, where you should be discussing the stations, presenting the stations to each other. That's the best way to learn and to prepare for this exam, when you can get an honest feedback and can improve station by station. Of course, in the course, we give opportunity to the candidates to prepare and to present the stations, and the mentors give active feedback. Not only the mentors, the other participants also give active feedback. So this is how we learn together. So you all are aware of the rules and regulation. It's a standalone exam. Earlier, now it's long, it's around 5 years now. Earlier, the part 2 and part 3 were a linked exam, part 2 written and part 2 OSCE, which used to happen simultaneously. And if you couldn't clear the OSCE part, you had to give the written exam. Thankfully, it has been separated. So once you pass part 2, you don't need to go back to part 2. It should be attempted within 7 years of the Part 2 exam, and you are allowed 4 attempts after Part 2 exam. So the venues and the dates still not out. Hopefully, the exam goes on in May. It's high time the exam happens. All of us are waiting for the Part 3 to happen. We'll be giving you information as soon as it is available on this. So you all know it's a circuit exam. You're moving around in the circuit. There are 14 stations. You have a 2-minute reading time and a 10-minute actual time. So for each station, you start with the reading time in which you have a question or the station displayed there in which certain information will be given to you. You have to read in that 2 minutes. You have to read that information, assimilate that information, and decide what you're going to do in the next 10 minutes. So what you do in those 2 minutes decides what you will do in the next 10 minutes. So that's important. Again, later on, we will be discussing what to do in these 2 minutes. And at the time of preparation right now, you have to train your brain. This is, again, which comes with repeated practice. You have to train your brain to think quickly, to assimilate the information quickly, and understand the station in those 2 minutes time. Because if those 2 minutes are gone, if you're using the thinking time in the next 10 minutes, you won't be able to finish your station. So this is a very important point. The total duration of exam is 168 minutes. These 168 minutes determines whether you become an MRCOG after that exam or not. So all of you know, they are the role player stations or the simulated patient task. You have a role player or an actor there who will be simulating an actual patient. The teaching stations also have an actor who plays the part of a junior colleague. And there are structured discussions which are with the examiner. So examiner is the senior consultant and you are the junior colleague in that case. 4 stations in the exam will have a lay examiner. So these stations will have a lay examiner as well as a clinical examiner there. So lay examiners are basically members of the lay public, but who have been trained in the questions of the exam, in the marking of the exam, and they will also mark you as a lay person in your various communication skills. So as I said, it's a circuit. There will be 14 cubicles in the circuit and 14 candidates in that circuit at one particular time. The candidate instructions are pasted outside the cubicles. So when you're in your allotted 2 minutes, you are standing outside the cubicles and reading those instructions. On the same day, generally they are the same stations will be there. Of course, they separate the morning and the afternoon batch, so they cannot communicate with each other. So we were talking about the lay examiner. So those stations in which 3 people are sitting. 3 people means 1 role player, 1 clinical examiner, and 1 lay examiner. So you can imagine for those particular stations, the clinical examiner as well as the lay examiner is marking you. So these stations are the highest marks. You must remember, all stations are not equivalent in the weightage. Some stations will be weighing more than the other ones. So you rotate around the stations, there's no break. So you rotate from one cubicle to another till you finish your 14 stations. So as I said, it is that 168 minutes to the degree of the MRCOG. So you know about the modules. The curriculum remains the same. It's the same what you have already read for and prepared in your Part 2 exam. But of course, how we handle the curriculum is quite different from the Part 2 exam. So the various modules, just as a recap: teaching, core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor, management of delivery, postpartum problems, gynecological problems, subfertility, sexual and reproductive health, early pregnancy care, gynecological oncology, urogynecology, and pelvic floor problems. Also, there are certain miscellaneous things which may not be covered particularly in the modules, some things like clinical governance, we will be doing, and some miscellaneous topics which particularly I cannot place in a particular module here, but we'll be doing stations which pertain to those miscellaneous topics as well. So what are these domains? So you all know the marking scheme is based on domains. So there are 5 domains which make this exam: information gathering, communication with patients and their relatives, communication with colleagues, applied clinical knowledge, and patient safety. For each station, they will tell you, okay, these particular domains are tested. And the marking is pass, which is 2 marks, borderline, which is 1 mark, and fail, which is 0 mark. And when the result is calculated, the total marks from each domain of each station will be added, and your result is calculated based on that. So you have to reach, so each exam will have its cutoff, which is kind of similar to the Part 2. So if you reach that cutoff, you clear the exam. You don't have to individually pass in each domain in the exam, but if you reach the cutoff, you clear the exam. Of course, it does mean that you have to do well in all the domains in the exam. So all domains are important, and let's see what these domains mean for us. The first domain is information gathering. Now, information gathering is how you start your station. You go to the patient and you have to ask the history from the patient. The most important way to score in the information gathering is that you need to have an organized template in your mind. You must remember it's a 10-minute station. Maximum you should be spending on information gathering is 4 minutes, 3 to 4 minutes. So maximum 4 minutes. If you exceed, maybe 4.5 minutes, but not more than that. Why I say that? You speak for 4 minutes and gather information. The role player will take at least 1 to 2 minutes. So 6 minutes are spent overall in the history taking and the patient replying to you. So you have only 4 minutes now to make that diagnosis, explain the diagnosis to the patient, and explain the management plan to the patient. So you can imagine if you exceed the information gathering too much, if you take history for 7 minutes, you hardly have 3 minutes, and your station won't be complete, even if you know the station very well. So it's very important for you to finish your history taking in 4 minutes time. How do we finish the history? When you are preparing, when you are talking, you need to time your history taking. The whole template, are you able to speak in 4 minutes, is what you have to practice. Plus, you must remember That should include the time taken for the role player to respond to you. That's important. So having an organized template is the most important. You should not be thinking, oh, what is the next question I should ask? It should come quickly, step by step in your mind when you are doing the actual station in the exam, and that comes with practice. So the information gathering involves the history taking, the examination, and then the investigations. It's very important that you should know, if when you talk about examination of the patient, of course you are not going to physically examine the patient in the exam, but you should be telling the patient, I would like to examine. The second thing you should remember is that you have to justify what examination are you doing. So similarly, you have to justify the investigations and what investigations you are going to do for that particular case. The history constitutes of open and closed questions. You should be able to interpret all the history, examination, and investigation to make the diagnosis and to make a plan for management. That all happens in your 3 to 4 minutes time, and the later time is what you will actually utilize to explain this to the patient. So always you will start with, can you tell me more about your complaint? So when I say open questions, it means, can you tell me more about your complaint? And that is followed by the closed questions, which you can ask in detail. We'll be discussing the template in a short while. The next domain is communication with the patients and their relatives. This domain is most important, and this domain is what actually is confusing, especially when you're beginning the preparation. Of course, as you do more and more sessions, you know and you understand better how to communicate. So important is, to introduce yourself. You say that I am Dr. XYZ, and I am the doctor in the clinic today, or the registrar on call, or registrar in the delivery suite, and so on. And then you ask the introduction of the patient. So initial part of any dialogue with any person is introducing yourself and confirming whom are you talking to. Another part of communication is empathy. Empathy means that you understand what the patient is going through. And it's not sympathy, it's empathy, that you understand what the patient is suffering or going through, and you deal with the emotional as well as physical aspect of the patient's problem accordingly. Another important part is honesty. You cannot hide facts from the patient. You have to be very forthcoming and honest about what you tell the patient. The next aspect of communication is signposting. What is signposting? Signposting is involved in the communication in different scenarios. One is the breaking bad news. So you'll be hearing about breaking bad news from Dr. Sidra. So breaking bad news, before you break the bad news, you have to signpost. Signpost means that you have to say something or give an introductory statement so that the patient is mentally a little prepared or ready to listen to the bad news. Suppose very common station will be something in which the patient has been diagnosed as a cancer, and you have to tell the patient that. So instead of just blurting out the diagnosis, you have to say something in the beginning. So you say that, I'm sorry, but I don't have good news for you. And then you take a pause and you say that your reports show that you have cancer of the lining of the womb. So these kind of sentences is what you have to practice now, so that when the station comes in the exam, you don't have to think about it. And this is what we do in the course. We tell you these lines which should come very naturally to you because you have already practiced them multiple times. Another kind of signposting is when you have to ask sensitive questions. So as I said, one kind of thing is when you're breaking the bad news. Another type of signposting is when you have to ask sensitive questions. Sensitive questions like smoking, alcohol abuse, and so on. So suppose you have to ask about an alcohol abuse, you say that I'm sorry to ask you certain personal questions. They might seem embarrassing, but I need to ask because I want to, I ask these questions from all my patients. It will help me to plan your management, and so on. So the sensitive questions may be about something like, as I said, alcohol or drug abuse, or it may be something like when you are asking about sexual history of the patient, which might be embarrassing for the patient. So you need to be gentle, you need to signpost so that the patient is feels more comfortable to tell you these answers. Why it is important is that in the exam, it's not an actual patient. It's a role player there. And in their script, they are given instructions. Like if the candidate is not sensitive, they may not even answer. They may not give you the information. And this information would be or might be necessary for you to actually, understand and crack that station. So it's very important. The other part is, which we all know, avoid medical jargon, use layman terms, simple language which a layman will understand, and use various aids to explain to the patient. Aids means you can draw a diagram, you have a pen and paper there, you explain with the help of a diagram so that improves the understanding of the patient. So all these things come in communication with the patient. The next domain is communication with colleagues. Now, communication with colleagues it will be a domain in the structured discussion stations in which you have an examiner who will be asking you questions. So the examiner is your senior colleague. So the communication style here is different from the communicating style when you are talking to a patient. There you are explaining in layman terms, you are avoiding medical jargon, you have to be sensitive, empathy, you have to change your tone accordingly. With the examiner, it means that you are a registrar talking to the consultant. Here you have to be professional, you have to use scientific terms, and you should be sure of what you're saying so that the examiner feels that you are capable enough to make a diagnosis and plan the management for the patient. So that will be communication with colleagues. Another aspect will be when you're doing a teaching station. In the teaching station, usually you are the senior colleague and you are talking to a junior colleague who may be an ST1, ST2, and maybe you are explaining about a procedure like a forceps delivery or shoulder dystocia. So then you are able, one second. Sorry for the interruption. So with the junior colleague, it will be different because you don't have to be patronizing. You have to explain them, check the understanding of the junior colleague, and you may have to deal with issues like bullying. So it will be different. But again, you have to show professionalism in that manner. The third aspect of communication with colleagues is the liaison with other specialties. This may be a part of a role play session as well. When you're talking about a multidisciplinary team, as maybe in case of an oncology station or a urogynecology station, you have the specialists, you have the nursing staff, a specialist midwife, specialist nurses, then the ancillary healthcare individuals like a psychiatrist or psychologist. So all these people form the multidisciplinary team, which is also communication with colleagues. The GP and the community midwife, the hospital nurse, all these will part. So the liaising with the various specialties is also part of communicating with colleagues. The next domain is applied clinical knowledge. Now this is a self-explanatory domain. This is the simplest to understand. You use the knowledge you gain. Actually, it's the knowledge you have already read about in your Part 2 exam. Your guidelines, your green top guidelines, your NICE guidelines, the STRATOG, the TOG articles, all the things, all the information and the knowledge you apply in your station. So it's from the name itself, you can know, okay, yes. So how do you use that knowledge? First thing, you make a diagnosis using that knowledge, and then you make a plan for the management. That the station may be a gynae station or a pregnancy or obstetric station. So normally in an obstetric station, when you make a plan of management, it includes the antenatal care, intrapartum and postpartum care. Okay. When you make a plan of management, like I'll give you an example. Suppose it's a high-risk pregnancy, such as a medical disorder with pregnancy, chronic kidney disease with pregnancy, or heart disease with pregnancy. In the station, you have to understand that this is a consultant-led care or a joint care, a multidisciplinary care, the obstetrician, the cardiologist, as in a heart disease patient. So this is what you will have to speak in the exam. You tell the patient you will be under the consultant-led care, or you will be cared for by a multidisciplinary team, including the obstetric doctors, the heart doctors, the psychologist, or the case may be. So this you have to tell the patient. Then another example is something like a gynae case, like a heavy menstrual bleeding case. If you have to form a plan of management, it may be a medical management, surgical management. So you explain to the patient all types of management, tell about the pros and cons of each, and help the patient to decide. Again, you should not impose your treatment on the patient. You give the information of the patient and let them take a decision on their own. So you help them to make a decision. Also, applied clinical knowledge includes counseling about a procedure and the knowledge about the complications. Then comes the domain of patient safety. Now, this is something which everybody is worried about, the patient safety domain. This is a cause of confusion for most of the candidates. What does come in patient safety? As I will give you various examples of patient safety, and then you'll understand. It is something which you usually do in your daily clinical practice, but we don't know exactly what we are doing is dealing with patient safety. So, example, high-risk pregnancy. You analyze a patient and decide this is a high-risk pregnancy, and this patient should be under consultant-led care under a multidisciplinary team. That itself is patient safety. You ask the patient about drug allergies. That's a very important point. You should not miss that in any station. You ask the patient about blood group, especially an obstetric case, because any obstetric case may have, and the patient comes especially with the antepartum hemorrhage or early pregnancy, bleeding, you should know the blood group. Then you should be, when you're doing a procedure which requires antibiotics, you should be prescribing antibiotics for that. You should be aware of which drugs cannot be used in pregnancy, which are contraindicated in lactation, and the safety. Again, this is a patient safety point. When you talk about smoking, alcohol, recreational or drug abuse, that is also important. That is a patient safety, because if the patient is smoking or taking alcohol, you advise them to stop smoking or stop alcohol, and you refer them to the NHS stop smoking or NHS drug and alcohol services. That again, you are actually taking care of patient safety. You decide in an obstetric case that this patient is at high risk of thromboembolism, and you give thromboprophylaxis. Then when you're dealing with young patients, and we make it a point to do stations with young adults, that's very important, because they form a separate group, a group of their own. When you're dealing with the young patient, you should be understanding about what are the special issues when a young person is involved. That is also patient safety. Another thing which you should remember is that when you know what is your limitation. So in the exam, see, I know most of you are very senior people. You may be consultants in your own region, and you're dealing with all kinds of patients. But in the exam, you are the SC5 level. So this also we have to understand. So you should be knowing what an SC5 can do. So patient safety also involves that you call the consultant when it's a complicated affair, complicated case. Suppose a bladder injury happens in a hysterectomy case. So you should call somebody, call your consultant, or you call the urologist. You may be able to repair the bladder yourself, but as far as the exam is concerned, recognizing your own limitation is also patient safety. Okay, but of course, you should not always call consultant or discuss with your consultant. That shows that you're not confident enough. So there has to be a balance there. Then issues like domestic violence, child safety, you think a child is under the child safety issue, you call the child safeguarding team. That is also patient safety. Bullying, that may happen in a teaching station. You should know that one of the exams, there was a station that it was a teaching station in which the candidates were asked to teach forest plot to the junior colleagues. And actually, it had a hidden agenda of bullying. So when we talk to you about teaching stations, we also talk to you how to understand bullying and how to take out that hidden agenda. Similarly, hidden agenda of domestic violence, of sexual abuse is something which we should be aware of always when you are talking to the patient, especially obstetric patients. Risk management and applying risk management to different stations is also coming under patient safety. In a postpartum patient, you talk about hand hygiene. This was taught to us in a RCOG course, and then that also shows patient safety. In the examination, those of you who have you have practiced the stations, you know that you say that, okay, I will examine you in the presence of a chaperone. So when you talk about chaperone, it is to maintain the patient dignity. That also is patient safety. So these are the points of patient safety which you are actually doing in your daily clinical practice. But this is what you should remember when you talk about this domain. So other things we normally give you a list of things we should be knowing when you're talking about patient safety, like, you know, the WHO safe surgery checklist, the enhanced recovery, the incident reporting, drug interactions, mental capacity, correct prescription writing, child and adult safeguarding, all these things, consent, this is all patient safety. Okay. So that is about the domains in general. And so what do we do outside the cubicle? What are you going to do outside the cubicle is the question. So as I said, these 2 minutes are very important. The question you should ask yourself is, what do I do? So you have to think where, who, what, how. Where are you in that station? So the question will tell you, you are the registrar in the fertility clinic, or you are the registrar in the delivery suite, or you are the registrar in the A&E. So you should know where are you there in that station, and who are you? You are the ST5 registrar, or you're the ST4 registrar. Then what is the station about, and how are you going to manage it? These are the 4 questions you should have answered by the time those 2 minutes are over. So important, you see the age of the patient, you see the main finding, what is the main problem of the patient, and then you try to make your diagnosis. You should always write down the important points on the paper. So you will be given a notebook in the exam along with a pencil. It's not a pen, it's a pencil. So just start practicing writing with a pencil. I know many of us have stopped writing with pencil ages back, but now you should have a pencil and pen when you are preparing for the exam. So write the points. What do you want to ask the patient in this case? Secondly, what do you want to tell the patient in this case? Okay. Also important to know, some stations in the exam have multiple papers, and nobody is that, you know, even superhuman people among us may not be able to read all those papers fully in those 2 minutes. Please remember, the same station is also pasted inside on the table. When you go inside the cubicle, on the table, you have the station again. So if you're not able to read outside, it's fine. You can, you know, go inside and read. You can excuse from, you know, take excuse from the patient or the examiner. You can tell them, sorry, I just want to recall your blood tests or investigations before I talk to you. Is that okay? And then they will say, okay. And then you take those 30 seconds to read the station inside the cubicle and then start your station. Don't get confused. Don't get panicky. And because that will spoil your whole station. So very important for you to remain calm. So this is very important. Secondly, don't carry forward your emotions from the previous station. So you are moving in a circuit in the exam, correct? So you do one station, and that, unfortunately, that station goes very bad. If you keep thinking about that station, you should remember there are only 2 minutes for the next station. So if you keep thinking about your previous station, oh, I did very badly, oh, I'm done for, then it will spoil your further exam also. So please remember, nobody does very well on all the 14 stations. You should do fairly well on many stations. Even if 1 or 2 stations are bad, it's okay. Just move along, just move ahead. That's very important. So these are the tips you should remember, and this you should be telling yourself again and again, so that this is ingrained in you when you actually reach the exam center. So these are about the 2 minutes. So what do you do about this in your preparation? Because we are discussing tips and tricks not only for the exam, but for your exam preparation. Whenever you are doing a station, whether you are doing it from a book, or you're doing with your friends, or you're doing in the course, these 2 minutes you should use exactly the same way you're going to use them in the exam. Always when you are reading, even from the book, time yourself. Don't give yourself more than 2 minutes to read the station in the book also. Use those 2 minutes, keep a paper and pen, keep your copy and your pencil in hand and write down what do you understand from the station, the same way you are going to do it in the exam. Don't give yourself more than 2 minutes to read the station, even when you are doing from the book. That is the most important tip for you today. And especially in the course also, if there are 10, 12 participants in a course and only one person is presenting, the others also should do the same thing. Paper and pencil, write down. Okay, this is the station, this is what I want to ask, this is what I want to tell the patient, and these are the salient points. This is very important. So, as I said, who are you? You think like a UK trainee at the ST5 levels. You should know the right things. You should know your limitation. You don't need to do more than you should be doing, because that again affects the patient's safety. Okay, so now you have spent those 2 minutes outside the cubicle. Now you are entering the cubicle, and now you have 10 minutes to finish all this list. This list includes your introduction, set the agenda, ascertain the concern and knowledge of the patient, gather the information in a structured manner using your templates, interpret the history, examination, investigation findings, explain to the patient the diagnosis and the management, keep checking the patient's understanding, summarize, provide written information. We all keep talking about the patient information leaflets, provide that, close the session. So let's see, how do you do that? Please remember this is not a questionnaire that you have to place in front of the patient and just get the answers and write them. This is a dialogue going on between you and the patient. You have to react to it. You have to follow through what the patient says. So of course you should have a template or structure in your mind, but you should be actively reacting to the situation which is happening. So you start with, you introduce yourself. Okay, I am Dr. This and this. I'm the registrar in the delivery suite today. May I confirm your name and age, please? Patient says your name and age. So you say that, then you set the agenda. You say that today, I understand. Okay, so you have a letter from your GP saying she has heavy menstrual bleeding. You say that I understand from the letter from your GP that you are having heavy bleeding during periods. Today's discussion, I'm going to ask you more questions about you. I may need to examine you, and then I may need to do certain investigations, and then I will discuss your management plan with you. Later on, I would give you some written information and write back to your GP. Now, if you have already set this full agenda, even in the end, if you don't have time to talk about the patient information leaflets, examiner knows that you've already talked about it in the beginning. So this is another tip you should remember. Okay, what I mean is, in the beginning you say that at the end of the session, I am going to give you some written information about this problem and write back to your GP. So you have actually closed the session in the beginning. You have covered the written information, which may be carrying a mark form. Okay, so setting the agenda is very important. So when you start with open-ended questions. Can you tell me, again, I go back to heavy menstrual bleeding. Can you tell me more about your problem? She will say, oh yeah, doctor, I bleed every cycle, this thing. Then once you get the main problem, you can ask close questions, specific questions. Okay, do you have any intermittent bleeding in between the periods or bleeding after sex? So that is a close question. But then after you've asked the open questions, these are the more specific questions in which you rule out, certain things. In a gynae case, it's very important to ask, how is it affecting quality of life? I mean, like at the heavy menstrual bleeding, you say that, how is it affecting your day-to-day life? So this is the main concern of the patient. So you have to ask that, okay, ascertain this. Then in the information gathering, you should, how do you ask? The obstetric history, suppose you say. So if you ask how many children you've had, the patient will say 2 children, and then she may have had 1 ectopic pregnancy and 3 miscarriages. So you said that, have you been pregnant before? Says the doctor, yes, I've been pregnant. So how many times have you been pregnant before? Can you tell me more about your pregnancies? And then you start from the first pregnancy to the end. So you know in each pregnancy whether it was a miscarriage, it was an ectopic, it was a full-term normal delivery, and then or a cesarean section. Then you ask, then if the miscarriage is relevant, you ask, okay, did it happen on your own, or did you have an abortion? And may I ask, I'm sorry to ask you that. I know it's a personal question, but may I know the reason for that? You say it's for social reasons, that's fine. These questions you should be very sensitive about asking, as we discussed earlier in the communication with the patient. Then during the history of the present pregnancy, was it a planned pregnancy? She says yes. You say congratulations. So this is something, it's you responding to what the patient is saying. It's not a questionnaire. You have to react to what she says. Okay? Or she says, oh, doctor, it was a miscarriage. I'm very sorry to hear that. So you respond. It's a dialogue. You should remember it's a dialogue between you and that's what is communication with the patient. Have you done your booking bloods? Have you done your scan? What were all the tests okay? So that you know that, till now everything has been going on okay. Then it's a term pregnancy. And this, I've seen many candidates and students forgetting this thing. If it's a term pregnancy, later half the pregnancy, you have to ask what, do you feel any pain right now? Do you have any watery discharge? Do you have any bleeding? Are you feeling the baby's movements? This is something which you routinely ask your patients in your clinical practice, isn't it? So you should be asking this about contraction pain, leaking liquor, saying watery discharge, bleeding, and movements, whether she's feeling or not. Okay. Like, and another example I will give you of a case of infertility. So it's important to know, because they may be having different partners, whether she has any other children. If she's coming with fertility with the current partner, has she got any children from the other partner, whether partner has any children from another partner, because that will decide their funding from the NHS and all that. So these things also become relevant. Sorry. So then you have medical history. You ask about, are you on any medication from your GP now or earlier? If she says yes, you ask more about, suppose it is a chronic kidney disease in pregnancy. So you should know more about it, what medication she is on, whether they are compatible with pregnancy. How's the control of her problem right now? If it's not under control, she has a proteinuria, hypertension, she becomes a very high risk in this pregnancy, and so on. When was her last visit to the specialist, like to the kidney doctor? Were there any admissions, like in asthma? All these things will determine how risky is this pregnancy now, and what extra precautions or measures you are going to take for her in this particular pregnancy. Now, suppose you are going to ask about oral contraceptive, or you have to prescribe oral contraceptive pill, then you may have to ask specific medical history, like whether she's on oral contraceptive pill, whether she has had breast cancer in the past, and so on. Then another thing which is relevant in obstetric cases is something like whether the patient is going to accept a blood transfusion, because they have Jehovah's Witnesses who are not going to accept the blood transfusion. So he said that, can I know would you accept blood transfusion if required, if needed? And then sometimes they are open to one particular kind of a component transfusion. So if they say, no, I will not accept blood, would you accept platelet or plasma? Other details you should be knowing. Then family history of any significance, and you ask about surgical history, social history. Social history means, okay, what do you do for your living? Whom do you live with? So you have to ask about the social circumstances. So whom do you live with? Do you have adequate support? Then social history also involves the smoking, alcohol, and the drug abuse. So you say that, I want to ask you some personal questions. These might sound intrusive, but I ask from all of my patients. Is that okay? or you could say that I ask them from all my patients as it would help me to plan your management and care. Is that okay with you? Okay, then she says, yes, I smoke. I smoke 5 cigarettes every day. So you can, then the next thing, you cannot just leave it at that. She's smoking in pregnancy. So you said that I am not trying to be judgmental, but are you aware that smoking during pregnancy can be harmful to the baby? Have you ever thought about quitting? Somebody's mic is on. Please, all of you, please, all the participants today, keep your mics off. Otherwise, it disturbs the class and it interrupts my chain of thought. Thank you so much. So you say that, have you thought about quitting? And then you say that, okay, I can refer you to the NHS Stop Smoking Services. And as I said, the drug and alcohol services according to what problems or what addiction she has and so on. Then allergies, then if it's a positive allergy, what kind of allergy was it? What's a big rash or she has swelling? It will determine what type of allergy and what she should do in this pregnancy. Then important, and especially when you're suspecting something like domestic violence or a psychological issue, ask about questions for depression and anxiety to finish your history. Of course, you may not be able to ask all questions in all cases, but you have to choose, and some basic things you have to ask every time, though the time is short. I know the time will always be short in any station, especially in a simulated patient task, but somehow we have to manage. And I said, and then in the end, you should be using such sentences like, anything do you want to add? Anything would you like me to know? So that, if the patient, if you have not asked something, the role player may say, yeah, I just want to add one thing, doctor. And that may be very useful to you. So that's important. Okay. Examination wise, you should tell them, I would like to examine you in the presence of a chaperone because, like if it's a menstrual bleeding, because I want to check the size of your womb and I want to check the ovaries and the tubes. Is that okay with you? Okay. So you justify what you're doing. You justify your examination, justify your investigations. Then when you discuss your care plan, you say you will be under consultant-led care, or you will be cared for by a multidisciplinary team. And when you talk about multidisciplinary team, you should know the members of the team and say those names. A chronic kidney disease pregnancy, you say multidisciplinary team, which is formed by us the pregnancy doctors, the kidney doctors, the specialist midwife, and so on. So that the examiner also knows that you have the knowledge about it. So this will be communication with patients plus applied clinical knowledge. So the domains are not completely independent of each other. There will be overlaps. So saying one point actually helps you to score in both the domains. So these are the things important for you. And then finally, and please remember, the suicide is the most common direct cause of maternal death there. So the mental health problems are very important. We should not forget about mental health. We will be doing a case on mental health in the course, and actually mental health is something which I myself got in the exam. So we should always be prepared for that. And I said, then in the end, you said that I will write back to your GP about your care plan, and I will give you some patient information leaflets, and I will these are some support groups which you can contact and which would help you better deal with the issue, and so on. Okay, so this is how you close your session. And then end, you can say, I am going to fix an appointment with you in 2 weeks time or whatever. I'm going to fix another appointment with you, and that if you have any questions, you can talk to us in the next appointment. This is how you close your session. So as I said, the key to exam is the communication skills, which will be tested in your information gathering. So information gathering is also communication with patient, communication with colleagues. So it is very important. So how to communicate? Listen to the role player. Bold, underline, and in red. So you can imagine the importance of listening to the role player. And that is what I keep on emphasizing each time, because this is very important. Your voice, calm, low, but firm. You are the professional there. You're the doctor. You have to be firm, but you should be calm. You should not be panicking. You should not get agitated, especially when you are talking to an angry patient or an emotional patient. You yourself should not get agitated. You should remain calm and firm. Empathy, you should acknowledge the emotions of the patient. I can see that you're upset. I can see that you're very angry. So it shows the patient, yes, you are actually have empathy and you're responding to them rather than just talking what you want to talk. So that's important. Non-verbal communications. Non-verbal communication is your body language. Patient starts crying, you offer her a tissue or a glass of water or a cup of coffee. It's, you just take out the tissue and hand it over to her. The tissue may be lying on your table. So this is a non-verbal communication. Then combination of open and closed questions, which we discussed. Targeted history. Don't waste your time. You don't have time in the exam. You have only 10 minutes, and believe me, the 10 minutes go super fast, especially in the exam. Simple explanations. Avoid medical jargon. Again, bold letters in red. Very important. Give information in chunks and check understanding. You have explained about a particular thing. You ask the patient, do you need any clarification? Anything you want to know further? This is important. Then be honest. Then again, duty of candor. If something has happened, if the complication has happened, you should be telling the patient, okay, it's your duty to say, I'm sorry to tell you that, but this has happened. Apologize when relevant. Giving an apology is not an admission of guilt. I am sorry that this has happened. It doesn't mean that there was a mistake on the part of the doctor or the healthcare system, but it has happened, but you are sorry because you feel for the patient. This is what it means. So it is not an admission of guilt. So apology should be very forthcoming in all these cases. Okay, so let's go to how to prepare quickly. So the study material is the same. Your green top guidelines, NICE guidelines, the FSRH guidelines, the contraception guidelines, the TOG strategy. Courses, offline, online, mostly I don't think there'll be any offline courses in this scenario. So we'll all have to depend on the online courses. Preparation with colleagues, which is most important part. If you don't have a study partner, you make one today. You have around 30 people listening today. You should find out, or on Facebook or Telegram, you should try to find a study buddy who has your same wavelength, who may be in the same time zone, and you should be able to practice with. It's very important. And practice and more practice is important. So what to study, as I said, guidelines, patient information leaflets. So patient information leaflets become important in this part of the exam. So this is something which you may not have studied in the part 2. Of course, the patient information leaflets are designed from the guidelines themselves, but you can but they are in the patient friendly language, in the layman terms. So when you ask me how do I start preparation, whatever case station you do, you start reading the patient information leaflets along. The talk articles, the books. The first book to start with is the Lisa Joel's book. It's a part 3 MRCOG or Essential Revision Guide. It's the basic book. It tells you about all the domains, the basic things of the exam, and it gives you stations with 4 videos as well. So this is the book to start with. How each domain is relevant in each module is beautifully explained in this book. So first book to start is this one. The second book which I love and which I recommend to everyone is the task for Part 3 MRCOG Clinical Assessments by Sambit Mukhopadhyay and Medha Sule. This was, the first edition was in 2018. This has around 75 stations, well explained and references given very nicely. This is the book to do after you finish these JERs. Simultaneously, get through MRCOG Part 2 by Justin Clark and Kumaraswamy. This book is very relevant and useful because it tells you the lines which you should use. So the communication part is very nicely explained in this, and how you should use the lines. The chapter on audit and risk management is quite good in this book. So this is again my go-to book for reading. Then Tony Hollingworth, OSCE for MRC Part 2. It's a little older book, but this is very good, especially for structured discussion stations. Of course, there will be many books, but these are the, if you can finish off these 4 books in these 2 months, good enough. Now, there will be certain tricky scenarios in the exam, which we'll be doing in the course. Hidden agendas, as I said, domestic abuse, bullying, angry patient relatives, complaints, patient is complaining, complication is surgery, breaking bad news, dealing with young adults, the HFEA guidelines, which involves the guidelines for the fertility, surrogacy, assisted reproduction techniques, which are tricky and which we should understand very well before we go to the exam. So unless you have done these things before going, it's very difficult to do first time in the exam. These things have to be practiced before you go for the exam. This I've already explained. The history template should include an introduction. History of presenting complaint should be first. The obstetric history and the gynae history, depending on what kind of case. So if it's a gynae case, the gynae history comes on top. And it's an obstetric case, the obstetric history comes on the top. So it's an obstetric case. You have the history of the present pregnancy and then the obstetric history. Contraception, cervical smear, medical surgical history, drug allergies, family history, social history. Social history includes the occupation, partner, social circumstances and support, drug and alcohol and smoking addictions. But yes, you should modify the history according to the situation. So if we are talking about May 2021, you have 2 months, need to have a strategic preparation, divide your time wisely. So if you're doing the course, preparation with the course and the self-preparation should go side by side. And both are not, they are complementary to each other. And the time will always be short, but yeah, if you do the basic things very well, it's not very difficult to pass this exam. So strategy and planning, this is some of my strategies which I use, which may be helpful to you all. Of course, each person studies in a different manner. I say that one size doesn't fit all. So one kind of preparation will not fit all the candidates, but you can, think about what I have written and you can imbibe it in your preparations if you like this advice. So make template for each module, write down as many as different stations. This is something which I did. I have written many stations fully, including I am Dr. Pooja and I am the registrar in the delivery suite today. I would write that line also in each station. Write down the special lines. As like I'm telling you, I know these are sensitive questions. They might sound intrusive, but I ask them from all my patients and it will help me to develop your care plan. I would write this line 4 times, 5 times so that I remember it, and it's very easy for me to speak during the exam. Watch the videos. There are videos from the Lisa Joel's book. There are videos on strategy, which are very nice. And these videos they will do the simulated station so that you can see that and see that how you can improve your own station. Books, as we discussed, strategy is very vast. It is practically impossible to do the strategy for the part 3. I could never do it for part 2 as well. I mean the full strategy. But there are few modules like the sexual and reproductive health, which is quite good and it's more concise in the strategy, which one can read. Of course, those things which are not very well given in the guidelines or the talk, you can do from the strategy. Write down queries, points of confusion, and ask during the sessions if you're in the course. And we have a Telegram group which will be dedicated to the course members, and the queries keeps coming, and then we keep replying as soon as possible. During the session, and as I said, when you're even reading from the book, whether you're presenting, whether you're active listening, or if you're reading also, paper and pencil. Use pencil only, get used to writing with a pencil. So we are going back to the nursery and KG now. Then listen to the candidate, write down points. So the 2 minutes, as I said, write down important points for the station. Then listen to the candidate, write down points made and misses, and listen to the feedback and points about theory and communication. After the session, make notes, template, and write the stations in full in a dedicated notebook as much as you can. Practice speaking aloud with a friend and start preparing the next module. And then you have to revise whatever notes. The revision is very important. Revise relevant guidelines. So those guidelines which you think are important, which are getting repeated in stations, those guidelines which you could not do very well in part 2 and you think you can keep forgetting, because the structured discussion, you need the guidelines. So you revise them. Spend some time to read the clinical governance, which becomes very important in part 3. Keep practicing station with your friends daily, one-on-one or a group of people. Maybe you just do 1 or 2 stations in a day, but do every day. Give honest feedback. Be ready for bad feedback. Don't mind if your friend or the mentor or your colleague criticizes you in any way. It's for your own good. Repeat, and then suddenly you realize it's exam time. Commonly faced problems which we see once. So in the beginning, of course, you are quite confused about the simulated patient task, but as you keep doing, you get used to the communicating with the patient. But many a time, the students say that the structured discussion is very difficult for me to do, because sometimes it's very difficult to structure your answer in a logical manner. So because of this difficulty which was faced by ourselves when we were preparing for the exam, and then the students' feedback, we are holding a free session by Dr. Mohammed Hassan about how to deal with structured discussion stations. Also in the course, we have a separate session which is purely structured discussion. So all the stations in that session are structured discussions, so that we give you more and more practice on that. So before I go to I will do the two stations for you. Before that, I just want to quickly tell about synopsis of the sessions, and then we'll straight away go to the stations. Those of who we have few participants here. Those of you who want to present can raise your hand, and then you can do the station with me. So a session will be, we'll be talking about template for each module. We will be doing the high yield live stations with extensive feedback by mentors. We give you practice on difficult stations. Now, difficult stations for me and for most of the people will be something like audit, risk management, breaking bad news, hidden agendas where you get hassle. So before the exam, you should be having practice. Simulating, when we do a session in the course, and even today, we will be simulating the exam scenarios, giving you 2 minutes reading and 10 minutes active time. The post station, there will be a feedback by the mentor and even discussion with all the participants. So normally when I do the station, I first ask another participant to actually give feedback, okay? Because it's very important for you to critically analyze other people as well, because that makes your mind think, and that helps you to improve your own performance in the station. Then other important station of the modules we'll be discussing briefly. We also have 2 sessions on difficult topic discussions in which we discuss the topics like this. Of course, this list is not complete. We may add on this list. These difficult topics include angry patients, complaint procedure in the UK, dealing with young adults, sexual assault, mental capacity, breaking bad news, abortion laws in the UK, HFEA guidelines, bullying, undermining vulnerable populations, complications of surgery, confidentiality. What happens when you don't know the station, don't know anything about the station? What do you do in the exam? Disagreement between the doctor and the patient, labor ward prioritization, the gynae list prioritization, which is again an important uh, part of the exam, which all of us face difficulty. Then simple steps to high scores are focus on what matters, pay attention to the detail, listen more, talk less. Of course, you have to talk through the exam, but try to listen before you talk. Use the role player to your advantage. That's what we try to achieve when we are practicing. Stay confident, most important. Be positive. The exam is as simple as it appears difficult, and this is a true statement which you will realize when you give the exam. It 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 needs the strategic preparation. There is no two ways of going about it. Understand the exam. You have to understand the exam. You should understand what they are trying to test you for. Unless you understand that, you are not able to prepare for it. Listen to the role player. I keep writing this. I keep telling this again and again because it is important. Be calm and confident. When you're talking in the exam, you think that this is somebody who's like a patient in your clinic, and how confidently and how uh, well you should talk to your patient in the clinic. Similar thing you should be doing in the exam. Be empathetic and caring. Okay, before that, now I will go back to the, the two tasks. Before that, I just want to take a 2 minutes break, and I will be back. Those who want to present the station can type your name in the chat. Thank you. Hello all, thank you for waiting. Who wants to present the task? This is not the task I will project in a moment. Anybody who wants to, it's okay, don't worry too much about it. It's just the beginning of your preparation, so we don't, I know nobody's an expert here. But who wants to present? Because there has to be some candidate to present, then only I can discuss the station. Anyone? Anyone who wants to present the station? Nothing to get scared about. Okay, I just read the first name. Adila, are you there? Don't worry, I'm not going to force you. Adila?
Yes, Dr. Pooja.
Hi, Adila.
Hi.
Where are you? So let's take some introduction. So please introduce yourself.
I will try maybe. I just passed on the last exam, January.
Okay. Welcome to this session of Med Exam Expert. Would you like to try? It's okay. Like, I mean, it's not the exam yet. I know most of you, I think, have just cleared the part 2, and I can imagine what situation you are in because I was there. So
Yes.
yours was the first name, so I called you. Huh? Nothing, no offense or anything.
No worries. Yeah, this will be my first task ever.
No problem. So
Okay.
I'm going to project so don't worry about it. Whatever you do is fine. This is just the
Okay.
beginning.
Yeah. Okay.
I will give you a tough session. So, but you just try to do whatever you can. Okay. So
Okay.
I'm going to project the station in a moment, and your 2 minutes will start. Okay.
Okay.
So okay, you let me know when you want to turn. There is nothing. There is only this page, and then I will tell you about the domain. So your time starts now.
Okay. Okay.
So that's the only information here, but take your 2 minutes. Okay, Adila, your time starts now.
Okay. Hello, I am Dr. Adila. I am one of the doctor of the clinic today. How are you?
I'm good, doctor.
Um, may I confirm first your name and date of birth, please?
I am Diane, doctor. I'm 16 years old.
Thank you very much. I understand that from your GB letter that you have a concern regarding or some issue. Is that right?
Yes, doctor. You know, the labia, which what you call is, it's very big, and I'm really concerned about it.
Okay. Um, uh, I would like, because this is our first meeting today. Our plan is I will take some, I will ask you questions to know more about your problem. And then maybe I will examine you and our nurse will be a chaperone with us. And maybe we'll do some investigations and we will discuss according to that the management. Is that all right for you?
Yeah, doctor, it's fine.
Okay, maybe at the end of the our discussion today, I will give you some information leaflet or some like links if you can go and read more about your condition. Okay.
Oh, okay,
Uh,
doctor.
so first, I would like to ask you, how may I call you?
You can call me Diane.
Okay, you can call me Adila.
Okay.
So first, I would like to ask you about uh, your cycle. Is it normal?
Sorry.
Your period or your cycle, is it normal?
Yeah, doctor. I get my cycles every month, and it's all fine. No problems.
Okay. Do you remember at what age do you start your period?
5 days back.
5 years back. Okay. You don't have any problem, yeah?
No, no issues there.
So
I
I
just
would
have
like.
the problem with my, sorry, doctor, I have a problem with the labia because I have been seeing it for the last 1 year. I noticed that it was quite big. And then I went to the internet and I searched on the internet, and I think it's quite abnormal. And I went to my GP, but the GP said it looks okay. But I'm very worried, doctor.
Okay. So I would like to ask you, you said 1 year back you felt like it is abnormal or big than normal. Yeah?
Yes, 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 doctor.
So may I know what is your concern? Is just
I think
the
it's
shape, or do you feel it like became larger than it used to be?
No, I think it's quite big, and I think when I compare it to the pictures available, because I cannot talk to this about anyone else, and I think if I have a boyfriend, then my boyfriend would find it abnormal, and then I don't think I can be normal with this. I need a surgery, doctor. So can you help me?
Okay, I would like to reassure you regarding your concern. I will take a few questions from you first, and then I will examine you to see exactly what is going on. Okay.
Okay,
Um,
okay.
okay. Do you have any problem like excessive hair or acne?
No.
Did you have any like one in the family have this problem?
Pardon, doctor. Sorry.
Do you have any one in your family have this problem before?
No, I don't know, doctor. I have never talked to anybody about it.
Okay, no problem. Everything we'll discuss today between us will be um, between us, okay? So it is confidential.
Okay,
Um,
doctor. Yeah.
okay. I would like to ask about your height as well.
I think it's average.
Okay. Did you have any surgery down below when you child?
No, no
No,
surgeries.
no surgery. Okay. Okay. I would like to examine you, and our nurse will be with us like a chaperone. Is that okay
Yeah,
with
sure,
you?
doctor. Yeah. Okay, so all examination findings are normal.
Okay. Yeah. Diane, I think what I find is normal. You don't need to worry. It looks normal for me now. It is normal labia. Okay. So you don't need to worry. And at this age, I think you don't need any surgery because like we called it constructive surgery is not indicated in your case, Diane.
But doctor, the GPs told me the same, and you're saying the same thing. I'm telling you, like I have seen the pictures, and it's definitely abnormal. And I feel that I'm going to, stand out. I cannot fit in the situation. I'm 16. I'm not able to, you focus on my studies because of this. I need that surgery, doctor.
I totally understand your concern, but as my examine you and depend on my finding, I find it is normal, and the labia from female to female may be a different shape and different size, but yours is totally normal. At this stage, we don't need any surgery, and I can see you are like a little bit anxious, and this affecting your study, isn't it, Diane?
Yeah, it does, and I still want to go for the surgery. What are the risks with surgery?
There's a lot of risk for constructive surgery, but to be honest, at the moment, I don't have any evidence. For this reason, I will book you for another appointment with my consultant. Okay. But regarding your Diane, are you with me?
Yeah, doctor, I'm listening.
Yes, you are quite young as well. 16 is young, and your body is started to develop. So one of the issue, we don't do this surgery at early age like you, because you don't fully develop. Your body is still growing. For this reason, we delay any surgery. Okay.
So when can I have the surgery?
I think after you need to, I need to arrange with my consultant so he can explain to you in more details. But I think for me now you don't need any surgery, but because this affecting you, I think I suggest maybe some psychotherapy will be helpful for you at this stage.
Okay, I can consider that, doctor.
Okay, so I will arrange a referral to psychology psychotherapy. I think this is better for you, but I would like to reassure you this is according to my examination, and as I told you, you are still young and your body developed. You don't need any constructive surgery. But because this is affecting you and your study, I think at this stage, maybe we refer you to psychotherapy. Okay?
Okay, but still, I would still like to go ahead with the surgery whenever
Okay.
that is possible, doctor.
I understand totally. I will I will make another appointment with my consultant so we can discuss all the options again. Okay, and we'll address your concern. Is that okay?
No, okay, doctor. Okay, that's fine.
Do you
Thank
have
you.
any reference day so I can book you for appointment with my consultant?
Okay, sure. Okay, time's up.
Dr. Pooja, this is very difficult.
It is difficult. Okay, so we always start with the difficult cases because it's fine. Actually, you quite held your fort, and you said some good things. Of course, there are some misses, but I will talk about the positive points.
Okay.
I think the tone of talking to the patient was quite good, and you were not judgmental about it. You did talk about confidentiality, which is important, especially in a young adult. We should assure them of confidentiality. You did talk about reassurance. You talked about that there is variation in the labia in different individuals. You offered her psychological assessment and advice, which is another good point. And of course, you did laugh through the station, so it is difficult. The patient is difficult because patient has made up her mind that she's abnormal, and it's a young patient, so it is a difficult case. I told you in the beginning, so I think you did quite well at that. I'll just talk to a few people before I come back. Okay, Aisha is next on the list. Aisha, are you there?
Okay.
Yeah. Thank you, Adila.
Thank you, Dr.
For
Pooja.
participating in it. Yeah, it's very brave of you, and I commend you for that. Thank you.
Thank you very much for giving me this
Yeah.
chance. Thank you.
Okay, Aisha? Is Aisha there? Okay. Aziz? Aziz? Okay. Hamid? So people are scared to answer or they're not there. I don't know. Hamid? Hamid is what I see on my list. Anybody who wants to unmute themselves? I'm not going to ask you to do the station. I will be asking you about your feedback. Anyone who wants to answer? Humaira?
Ma'am,
Who's this?
I'm Monica, ma'am.
Hi, Monica. Yeah. So my question to you is, what else would you add now in history, in examination, and explaining to the patient?
Is she ever had any sexual experience like that
Yes.
with her
Okay.
permission? That we can ask, ma'am.
Yeah.
Any boy has passed some comment like that, and if the growth has to be assessed at the age of 18, and after that only the NHS allows any cosmetic surgery if necessary will be permitted, like that. That also we have to express to the patient, no, ma'am.
Okay. What else? What else do you want to ask a young patient who's come with this problem? One is, of course, if she's she has an experience sexually active. Does she have a boyfriend? Has that person told her that she's abnormal, or who has told her? Is it her own reading and viewing the internet, or is somebody else has told? So that is important. Yes. And
any peers should have passed some comments like that.
Okay.
And changing the dress like that. That also you can ask, ma'am. Then any is about education, scientific education or sex education being taught in the class like that. Did she receive any communication from the teacher like that? That also you can ask, no, ma'am.
And what else? So all the other important thing is she talks about school. So you should know, okay, which grade is she in? Is she doing well in school? Okay, yes, that's important. So the social aspect of is as important. Then what about her parents? Has she talked to it with her mother? So whether somebody has come with her or she's come alone, whether what is her relationship at home, how's the support at home? That's important. Okay, that's very important in these cases. Then yeah.
Her performance in the school whether that is being reflected like that.
Yeah, so that's important. So the social part of it is very important. So which grade is she in? Does she have friends? How's her performance in school? Of course, she's saying I'm not able to focus, but how is she doing in school? At home, who lives with her? Whether she lives alone, with her mother, whether it's a full family is there, is there support there? Okay. Whether then physically, how this labia is affecting her? Whether she has problems in, sports, whether she has problems during periods, whether she has problems in wearing tight-fitting clothes, and all this also is important. And she did ask about surgery, previous surgeries, their medical problems, about menstrual cycles. Yes, important is the sexual contact and whether she has a boyfriend. Also important in all. Pardon?
Excuse me, ma'am. Any discharge from that site?
Of course, yeah. Yeah. Anything else you want to add? Then I'll continue.
That's all, ma'am. Thank you, ma'am.
Okay.
Thank you, ma'am.
So then the next thing is that so young adult also important is the sexual abuse. You can mute yourself now, Monica.
Thank you, ma'am.
There's a disturbance coming. So the sexual abuse is important to rule out. As we said, the hidden agenda is important. So there may be sexual abuse which has prompted this girl to come in. So always rule out sexual abuse. So how do you ask about sexual abuse is that you will apologize or you will signpost that I'm sorry to ask you this question, but at any point of time, have you been forced to have any physical contact or sexual intercourse without your consent? You signpost, but you have to be, honest about or very clear about, firm about this question, because the safeguarding is important in this case. Okay. So also, if she's sexually active, you have to ask about contraception, any sexually transmitted diseases. That's important. So when you say that vaginal discharge, or have you been treated for sexually transmitted diseases? So this is in the history. Yeah. Aziz, you raised your hand.
Hello.
Hello, Aziz. Yeah.
Yes,
hello,
I had a couple of questions. The first one, how we can ask about the sexual abuse in the lay language, and the second one, and the second one, if the patient is insisting to perform the surgery, and this surgery from the scenario is affecting his physical and psychological impact. So can I end the conversation? Yes, I will arrange the surgery with the consultant because it's psychologically affected here, even if it is normal by the examination or it is normal variant, because as we know, in the female genital mutilation, we didn't perform any cosmetic surgery except if it is affecting her psychologically or physically. So if this could be option. And
okay, so first question I already answered. When you are asking about sexual abuse, it is that I am sorry to ask you this question, but it is important for me because I am worried about your safety. At any point of time, now or earlier, were you forced to have sex without your will or against your will or without your consent? You have to be straight in asking the question. This is what I was talking before you asked this. The second question is whether you can offer surgery. Of course, if you think now the doctor has decided the labia is normal, okay, of course you are not going to offer her surgery because she is psychologically affected, because it has a risk. So this station is basically negotiation with the patient. How do you communicate with the patient and negotiate with her to get across your point of view? She's just 16. Anyways, even if she has to do a cosmetic surgery, it will happen later. As Adila said, and what she explained well to the patient is that you are just 16. The genitalia or the labia is still developing. It's too early to do any surgery if it has to be done. So right now, of course, clinically, the surgery is not indicated, so you're not going to offer surgery. But you have to somehow, understand that she is very concerned about it. It's affecting her day-to-day life. And then you have to give her some plan of action at present. So more explanation is needed about how the surgery can actually harm her in this situation. So she understands that it is very risky to get surgery done at this young age. Secondly, you offer her because she's having problems with body image. So if you have ruled out sexual abuse, she has good relationship in the family, social support is good. She's doing well in her school. Otherwise, there is no sexual abuse, no sexual problems. Otherwise, it's only her own body image of what she has seen on the internet. So she keeps telling you. Now, this patient keeps telling the doctor, I've seen it on the internet. I've seen those pictures, and that is why I feel it is abnormal. So as I said, it is always a dialogue between you and the patient. So if the patient says something, you have to respond to that. But there was no response made by the doctor to those pictures. It's her information. So when you ask her, like, who told you? So in this case, she says, it's what I have seen on the internet is her source of information. So you have to say something about that so that she understands that it is not the only truth. So, of course, the issues, first I will talk about issues and then I talk about what we tell her. So first thing is, what do you note in this scenario? It's a 16-year-old. Okay, so that's important. It's a young adult, large abnormal labia. And if the examination findings given to you that it's normal, you know that she doesn't require surgery. She doesn't require any intervention, but she requires counseling and negotiation. So it's a negotiating station. Okay. Issues here, confidentiality. You assure confidentiality. Young adults important. You ask who's come with her, whether she's has confided in anybody else. What is the cause? Who's telling her that it's abnormal? Whether it's her own reading of the internet is what she says, or there is something behind it. There is a sexual, abuse there, or there's a boyfriend telling her. Who's telling her? Social circumstances. Where is the support at home? Is she having a good relationship with the parents, or she's a delinquent? That will change your management. Whether she is sexually active, whether she has any STD, contraceptive use, because that also you have to deal with. Suppose she is sexually active, even if she has come with abnormal labia, you have to offer her contraception. You have to talk about safe sexual practices. That will be patient safety point. So these things are important. So management of this patient, you have to address the concern of the patient. That's your main job here. You have to address her concern. You have to negotiate with her that she understands that surgery is more harmful than useful to her at this point of time. Psychological counseling, you should offer consultant input, which Adila said, and Monica also said, that's fine. And you use the Fraser guidelines. So you tell her that when she says that I've seen it on the internet and I feel it's very abnormal, you say that, Diane, it's common for girls. So what you can say, now I'm going to tell you the lines I will use here. Diane, it's common for girls of your age to feel conscious about the appearance of their labia or the external genital organs. There is a lot of variation in the appearance of labia and none of them is abnormal. Okay, so they may be of different shapes and sizes, but they are not abnormal. So, and many of the information which we obtain on social media or the internet, it does not show the true picture. Many of these images are retouched or of people who have already had surgery. So it shows the real appearance of labia of a very few women. Okay, and so these images may be distorted and not real. So you should not worry. You should not base your worry just on the base of these images on the internet you see. Now also you should know this, that there is a great wall of vagina which has pictures and charts of the external genitalia of many people. So you said you can use that aid. You said this is the this is a picture, this is a chart on great wall of vagina, and it shows the appearance, and all of them are normal. Okay. Before you decide that she has no problem, you should be asking her questions about, when she says it's abnormal, it's only based on her perception or the visualization of labia, or does it have cause any physical problem to her? Does this cause any irritation or discomfort during any physical activity? As I said, wearing of tight fitting clothes. Okay, any problem in periods, whether if she's able to use tampons, if you have to ask her whether she's using pad or tampon, whether it's easy. So this is first you ask her. Then you say that you first tell that the images on the internet may not be real, they are retouched, they are not representative of the labia of all women. Okay, that's important. You show her the great wall of vagina, this is the variation available, all of these variations are normal. You say that at this age, the second thing is any surgery should not be done before the age of 19 years because the labia is still developing. Doing surgery at this point of time will interfere with the growth and the development. Then any surgery will carry risk of bleeding, infection, wound complications, long-term risk may lead to fibrosis and scarring, and then the vagina may actually be less stretched. It can cause dryness, pain when she becomes sexually active. Also, when the nerves are injured, it can lead to loss of sensation. Also, you should tell her that even if you get the surgery done, it may not give you the expected results. Okay, many of the patients will feel they will need another surgery later on. Okay, so you say that the surgery has one is that this is not the age for the surgery. Second, the surgery has risk, may not get the same results, may have effect on sexual intercourse later on. Okay. Also, you talk to her, this is not funded by the NHS. The cost is 1,000 to around 3,000 pounds. NHS will not routinely provide this operation. Okay. So you say that right now, I know you are concerned about it. It's causing you psychological discomfort. And since you say that you're not able to focus on your day-to-day life, I will offer you, you should always offer you meeting with a psychologist. Sometimes talking to another person may help you deal with this issues you are facing. Are you agreeable to that? If she says yes, you refer her to a psychologist. Okay. And then you say, of course, I arrange it. You also encourage her to involve her mother. She said that is it okay if it will be helpful if you can talk to your mother and confide in her. And when you fix your next appointment with the consultant, maybe if you are okay, you can bring your mother and so we can discuss the things with her. Okay. So you should not be entirely dismissive of her concerns that, oh, no, everything is normal. Like whatever you are saying is wrong. No, you should say that according to the examination we have done, the labia looks normal. It is not a normal variation. But since you are concerned, we offer you one, psychological counseling right now. Have her confide in her mother, encourage her. Of course, you're not going to force her, but encourage her to say that labia keeps growing. We wait till the full development has taken place and the risk of surgeries. And then the surgery is not covered. Okay. So it should not be you against the patient. It should be you negotiating with the patient that you reach a common ground. Okay. So there is a British Society for Pediatric and Adolescent Gynecological Guideline, which is on labiaplasty. So you can go back and read on it. And then, so basically you explain this to the patient. So is it better, Adila? What do you think?
Yes, definitely. Yeah.
Yeah. So basically, I know it was difficult and for you to start with. So history, whenever young patient is involved, whether young patient has come for contraception or come for emergency contraception or for termination of pregnancy, you have to always, the things you should remember is confidentiality, sexual abuse, social circumstances, contraception, STDs. This should go for all cases without fail. This we should always remember. So how they are doing in their social circumstances is very important, like wherever, whether they are in school or university, or what is the social situation at home, what is the relationship between the parents, whether they're coming alone, whether they are, you always help to, encourage them to talk to their parents or the mother about it and, can fix another appointment with them. That's important. Of course, this you know it is normal and you will not offer her surgery, but somehow you should be able to, you know, tell her that this is the best for her at this point of time. Of course, later, you know, she may get a cosmetic surgery, and that's a different issue. That is a cosmetic surgery. But right now, clinically, it's not indicated. But yes, she needs something to assuage her concern. Is it okay?
Okay. Yes.
Yeah. But good attempt, I would say.
Okay.
Attempting it at this point of time is the best thing you can do, because once you do it, then it becomes better the next time. Of course, the first time it will always be problematic, and that happens with everyone. So nothing to feel bad about it. And it was a tough case, but I always start with tough cases, so then the easier cases seem very easy then later on. Okay.
Okay. Thank you very much.
Yeah, thank you so much. So as I said, all of you can read the British Society of Pediatric and Adolescent Gynecology BRIT SPAG guideline on labiaplasty. This is also a station in the book, the Oxford Task Book by Sambit Mukhopadhyay, Medha Sule. So it's a station there, and I did the station from there, and then I read the BRIT SPAG guidelines. So then I prepared this station like this. Okay, so this is the station for today. It's already midnight here at my end, so I will just end this session. All of you, please, you're most welcome to join the sessions tomorrow and day after with Dr. Sidra and Dr. Mohammed Hassan. I hope I have been able to make few things clear, not about this case only, but about the overall preparation. So this is how we go about it. And once you tackle a station, it becomes easier. So the difficult stations should have been done before the exam. Of course, there will be few new stations, and there can be unexpected station which comes, you know, 1 or 2 unexpected stations come in each exam. But if we are able to do 12 out of 14 stations well, those unexpected stations also you'll be able to tackle. So the idea is to be able to tackle different kind of stations. Of course, there's some specific difficult things we should have practiced multiple times, so that once it comes in the exam, it's very easy. Please remember, Rome was not built in a day. Your preparation will be a continuous effort. You will feel lost, you will feel frustrated and depressed in between, but that is all natural. That's, you know, part of the game. Thank you all for joining me here in this session. I wish you best of luck for the exam, and hope to see few of you in the course. Thank you so much. Thank you. Good night.
Thank you.